Friends, we are talking about the relationship between population and society, and in the last lecture I gave the example, two examples actually. One example from Emile Durkheim, which shows that rise in the density of population can lead to confusion and disintegration in society, but then the economic division of labor comes to society's rescue and things are taken care of. So, as population increases, division of labor also increases. Another theory by Kingsley Davis and Judith Blake, who gave a framework of 11 intermediate variables. This was called the theory of intermediate variables, according to which you can separately analyze the effect of any social change, say education, literacy, social mobility. I gave the example of social mobility. I showed how social mobility can affect fertility. Can it be fertility enhancing or fertility depressing if the impact is seen separately through these 11 intermediate variables. I also gave the example of migration, and in case of migration, migration is determined by socio-economic factors, and factors affecting migrants, factors at place of origin, factors at destination, personality factors, and certain special conditions like natural disasters etc., can promote migration. And thus, it is important to study the sociological variables behind migration. Migration also has certain impacts on social structure. So, the relationship between social structure and migration is reciprocal or symmetrical. Both sides, impact of migration on society and impact of society on migration have to be studied. I also mentioned about proximate determinants of fertility, which was an improvement over Kingsley Davis and Judith Blake's theory of intermediate variables, in the sense that now you can quantify the effects of different factors on fertility. Here in this lecture, I will show some of the socio-economic differences in fertility and related variables according to variables of sociology, which means say caste, community, wealth, etc. So, the structure of society and social stratification, they affect demographic variables, they affect fertility, they affect mortality. Karl Marx mentioned about this effect of social conditions on mortality among workers. And the less developed countries, as being the most rigidly stratified, the importance of studying relationship between stratification variables. By the way, stratification means that society is divided into a number of social groups, which can be arranged hierarchically in terms of prestige, wealth and power. Stratification affects demographic processes. India is often seen as a case of rigid stratification system, a system of caste based stratification. There are other systems of stratification like slavery, like state or like class, but India has caste as a basis of social stratification. It does not mean that other factors like slavery or class are absent. Class is very much there. So, some people talk of caste and class, and in some very isolated cases there is also the prevalence of slavery. Social stratification or rigidity of social stratification restricts mobility, caste is seen to be a closed system. Closed system with restricted mobility, aspirations of people to rise are low. Then when we connect stratification with demographic processes, we also learn that stratification is multidimensional. Stratification is multidimensional means poverty, deprivation, exclusion, they have several aspects. They have malnutrition, they have lack of housing, decent housing, they have low income and other related factors, class, status and power, as Max Weber says. India is a multicultural society, no doubt. So, cultural variables are also important, and therefore, demographers in India study their variables, demographic variables, fertility, mortality and often migration and domestic violence and knowledge of HIV and AIDS, prevalence and diseases. Epidemiological studies study diseases. NFHS 4 also talks about certain types of diseases, and we study differences in disease patterns according to these regional, class, caste, community and urban rural variables. The sources of data to study relationship between social stratification and demographic variables are National Sample Survey Organization, NSSO surveys. NSSO keeps on conducting surveys of consumption, on the basis of which we draw poverty line and are able to estimate whether percentage of people below the poverty line is rising or falling. NFHS, 4 rounds of NFHS, National Family Health Survey, SRS, Sample Registration Scheme and other surveys. One of the very important surveys is Human Development Survey. This is conducted by University of Maryland and National Council of Applied Economic Research. Many PhD students in our department are writing their PhD thesis using secondary data collected under Human Development Survey and applying, building mathematical models to explain those data. So, these are some major surveys: NSSO, NFHS, SRS, Human Development Survey, and we can make use of them. It is customary to produce data by urban rural residents. Urban areas are defined in certain way. In one of the lectures I mentioned that there are 2 definitions of urban areas, statutory definition and a demographic or census definition. Literacy and education also appear as independent variables in these surveys and analysis of data collected in these surveys. Then religion, very important, caste and income and wealth. These are the main determinants of demographic processes. Now, let us look at this table, and this table will show how stratification or socioeconomic differences among people produce differences in fertility. This shows the first figure 1.75 and 2.41, that total fertility rate in India according to the latest round of National Family Health Survey. In urban areas it is 1.75, which means in the urban areas by 2015-16 total fertility rate has gone below the replacement level, but in rural areas fertility rate is still high, 2.41, which is 0.3 above the replacement level. So, there are urban rural differences. I mentioned that urban, rural, caste, community, these are some variables according to which differences in demographic variables are seen. Schooling is another interesting thing. Schooling among women who are 12th or more years complete, those women who reported that they have done 10+2 or more, fertility has gone below the replacement level. and even among those who are 10th standard pass, it is 1.99 below the replacement level. So, one can draw the inference that if you raise level of education to 10th standard among women in India, among girls, today's girls, then you do not have to run family planning program, you do not have to spend money on family planning program, fertility will automatically come down to replacement level. Interestingly, even 8 to 9 years complete have 2.19, which is very close to replacement level of 2.1. The problem of fertility is the problem for those who are illiterate or less educated. Women who have no schooling at all have 3 children, and this partly explains why fertility among states of India, why fertility is especially high in Bihar and in Uttar Pradesh, because the proportion of women without schooling, without any schooling is one of the highest there. Those with less than 5 years complete have 2.43 and 5 to 7 years have 2.38. As the level of education rises, fertility declines. So, there is a clear cut relationship between level of education among women and level of fertility. Similarly, religion is another variable. Religion is not a variable of stratification as such, but of course, if you talk of exclusion as a process, then certain communities, some minorities, not all, some minorities may be excluded from participating in mainstream society, and that can lead to high fertility. If you look at total fertility rate for different religions, the lowest fertility rate is for Jains. Next to 1.20, you have 1.58 among Sikhs. So, Jains and Sikhs, they have the lowest level of fertility in India, and the reason is that Sikhs and Jains are the wealthiest communities of India. And the highest level of fertility is found among Muslims 2.62, higher than among Hindus 0.5, there is a difference of 0.5, and that can be explained to some extent by the exclusionary processes and by socio-economic deprivation prevailing among a large number of Muslim population. Now, similarly, if you go by caste, I mentioned that in India caste is the major cause of stratification. Caste explains social stratification and it is a closed system. At least this is what is believed to be, that caste is a closed system. It is endogamous, local and associated with a certain occupation. Here again you find that the highest fertility rate is found for forget about do not know, some people report that they do not know what their caste is, but among others the highest fertility is found among the scheduled tribes. Scheduled tribes are people who have been isolated from the mainstream society for a long time, and they have the highest fertility. Among the caste groups, you find that scheduled castes have higher fertility, followed by OBCs and then by others. Others have the lowest fertility. Actually, among others, fertility has gone below the replacement level of 2.1. They have only 1.93. So, high fertility is largely a problem of scheduled tribes and to some extent scheduled castes. Again, the reasons are socio-economic. NFHS has divided population of households according to wealth index, and again the differences are very clear. If you go by wealth index, take lowest to be the poorest people and highest wealth index by those who have the highest income, although wealth is not defined as income alone. Wealth is based on a number of characteristics pertaining to household. But if we interpret wealth largely as income, you find that those who are in the highest wealth quantile with highest income, highest number of assets and better quality of life, they have fertility rate much below the replacement level. And there is a negative correlation between income or wealth and fertility level. Those who are in the lowest wealth quantile, in the lowest 20% of wealth category, they have the highest fertility of 3.17, and this is correlated with regions, with caste, with communities and with other factors. So, that was the picture of total fertility rate. If you take another variable, a variable pertaining to effectiveness of family planning program, modern contraceptive methods by household wealth, you find that as wealth increases in this direction, then use of modern contraceptives also increases. Among those who are in the lowest wealth quantile, only 36% couples are using contraceptive methods, while in the highest wealth quantile 53% couples are using contraceptive methods. Currently married women age 15 to 49. So, I can say couples, in India we have monogamy, and corresponding to these women 15 to 49, we can talk of couples. Couples who have the highest income, their contraceptive rate is 53, and those who have lowest income, their contraceptive rate is 36. So, this is again indicative of the relationship between social stratification and contraceptive rate. If you go by state, this is the list of states which have contraceptive rates above the national level, and the highest contraceptive rate or highest use of contraceptive methods is found in Punjab, where percentage of currently married women 15 to 49 or couples in reproductive ages, 76% couples in reproductive ages are using contraceptive methods. Delhi, Himachal Pradesh, Jammu and Kashmir, Telangana, Odisha, Chhattisgarh, these are the states which have higher contraceptive practice than the national average. Now, Punjab and Chandigarh they are developed. West Bengal is not so developed. It is interesting to interpret why West Bengal has such a good contraceptive rate. Andhra Pradesh has high contraceptive rate. Maharashtra, Tripura, Haryana, Puducherry, Rajasthan, Chhattisgarh, these are other states which have high contraceptive rate, higher than the national level. And here is the list of states which have contraceptive use lower than the national average. And the state which has lowest use of contraceptive methods is Manipur 24, Bihar 24. Manipur is a small state, but it is worrying that a large state like Bihar has such a low contraceptive prevalence 24. Something has to be done. We have to focus our attention on Bihar, Manipur, Bihar, Meghalaya, Goa, Nagaland, Goa, these are again small states, Lakshadweep, Arunachal Pradesh, Daman and Diu, Mizoram, Dadar and Nagar Haveli, Jharkhand, Uttar Pradesh contraceptive rate is also lower than the state average, only 46. Then Sikkim, Gujarat, these states also have lower contraceptive rate. In this category of state, Uttarakhand, Tamil Nadu, Kerala and Assam and Karnataka have relatively better situation than other states. this diagram shows that certain categories of births have higher mortality rates. This diagram shows deaths in the first 5 years of life per 1000 live births, or what I in one of the previous lectures mentioned under 5 mortality. This is probability of dying before reaching the 5th birthday. There are differences between males and females. Probability of dying before enjoying the 5th birthday is higher for males than for females. For males it is 52, for females it is 48. Then mother's age is also important. You see, as age of mother increases, initially as age of mother increases, then under 5 mortality decreases, but after a certain age it increases. The lowest under 5 mortality is for the age group 20 to 29. Actually, this is the safest time when a lady can produce a baby who will survive. Before this, before 20, the chance of dying before enjoying 5th birthday is higher, and after that also it is higher. For those children who are born to mothers in the age group 40 to 49, under 5 mortality is particularly high, 104 per 1000, means one child out of 10 is going to die due to some or other cause before enjoying, before celebrating his or her 5th birthday. Then previous birth interval is also important, and all these factors, age at birth and previous birth interval, they depend on socio-economic characteristics of the couples. Here we find that if the birth interval is less than 2 years, then the under 5 mortality is highest, 75, and when it increases to 2 years it declines, 3 years it declines more, but for some reason for 4 years or more it increases. There is a need to explain why this happens, 4 years and more, why does under 5 increases. Maybe it is due to sampling fluctuation, one has to look at the size of the sample, subsample in these categories, or maybe it is confounded with some other socio-economic factors. Here we look at some other indicators of mortality, neonatal mortality, postneonatal mortality and infant mortality. Again we find that there are differences, but it is interesting that in case of neonatal mortality, males have higher mortality than females. In post neonatal mortality, males have an advantage. Perhaps this is due to neglect of female babies. In infant mortality also we find that mortality among males is higher, 43.3, while it is only 37.9 for females. Mother's age at birth, there is a dip 52 to 37 as we move away from less than 20 to 20 to 29, and then there is a rise in age group 40 to 49, infant mortality is highest. So, in the earlier slide we saw that under 5 mortality is highest for children born to mothers in the age group 40 to 49, and here we find that infant mortality is also high. Birth order is another important characteristic of birth, and we find that as birth order increases from 1 to 2 to 3, 4 to 6 and 7 and more, there is initially a decline in infant mortality and then rise and then rise. Similarly, birth intervals are also important determinant of infant mortality, neonatal mortality, like this neonatal mortality is lowest when the birth interval is of 3 years. Post neonatal is also lowest when birth interval is 3 years. Then birth size, very small, small, average or larger, and these are the figures. So, that birth size also determines neonatal mortality, post-neonatal mortality and infant mortality. Here we have direct variables on stratification and schooling. You can see that as schooling increases, earlier we had seen that as schooling increases, fertility declines, and those who have 10 to 11 years of education, those women have below replacement fertility. Here we find that among those women who have no schooling, infant mortality is as high as 41.5 and it declines to 18.6, as good as in some of the developed countries. Of course, further improvement is required in countries like Japan and Germany. Infant mortality is as low as 2 to 3. So, we can still make program interventions to reduce infant mortality further. But it is clear that as education increases, then infant mortality declines. Samely with religion. In religions, you find that 32.1 among Muslims is the highest infant mortality. Caste, scheduled castes have 31.1, scheduled tribes have 23.5, lower, OBCs have 32.1 and others have 22.7. There is highest infant mortality among OBCs, and this needs to be explained why. Similarly, wealth index, as wealth increases, we find that infant mortality declines. When wealth is lowest 20%, it is 46.7. In second and third quantiles, it is around 40. Then in fourth quantile, it declines to 27.8, and in the highest wealth category, highest quantile, it is 18.7. Here is a figure for health facility births by schooling. While those without schooling, among them only 60% delivered babies in health facility. Among those 12 or more years complete, 95%, almost all women delivered babies in school, in health facility. Coverage with all basic vaccinations by mothers schooling. This shows that as education increases, coverage of all basic vaccination. Government of India has declared that there are some basic vaccinations, and all those children who have been vaccinated for all basic vaccines, their percentage rises with education of mother. The policy implications of these data are that India is a democratic country, you can't force anybody to change behavior. Political power of a group depends heavily on its numbers in both rural and urban areas. So, M. N. Srinivas's concept of dominant caste. Post-modernization and globalization are producing strong ethnic group identities. People ask questions about differences in growth rates between different castes and communities, particularly communities these days, and NFHS has helped us in unearthing some of them. They must be addressed through both the approaches focusing on unmet needs of various types as well as involvement of community leaders. Can we go for community differentiated policy of regulation of demographic processes in India, as Russia did when in USSR fertility was very different, markedly different in Slavic and Baltic populations. They developed different policies for the two regions without bothering that there are religious differences, and people in Asian region of Russia may react negatively to these policies. Can India have different policies for different religions and castes? The answer is no, and you can think of why not. Why do communities and castes differ in demography? The reasons are cultural. Cultural means differences in norms and values. Some differences are because of socio-economic differences, and like this question, why do Muslims have higher fertility? Oftentimes people attribute these differences to nature of religion, but can we give the same answer here? Why do Jains have below replacement fertility, leading to 40% intergenerational decline in population? If the present trends continue, then there will be decline in population of Jains in the next generation, and in every generation there will be 40% decline. Can we say that it is because of Jain religion or religion propagated by Mahavir Swami that they have lower fertility? No. There the answer is their being the wealthiest community of India. Now, in place of attributing these differences in case of Hindus and Muslims to religion, can we also not say that it is because of exclusionary system that we have, social structure of India which excludes certain castes and communities, that creates differences in fertility rates or mortality rates or migration rates or social mobility or marriages. Marriages differences in age of marriage are closely associated with differences in fertility rates, mortality rates, neonatal, post-neonatal mortality rates and infant mortality under 5. So, these are cultural differences, both differences between different religions and different castes are due to both the regions, cultural regions as well as socio-economic differences. Sikhs and Jains show the lowest juvenile sex ratio. So, everything is not good for Sikhs and Jains. They have lowest fertility and that is good, but they also have lowest juvenile sex ratio. This is a cause of worry, not because of differences in religious philosophies, but because they are the wealthiest communities of India, and it has been found that gender bias is more among high caste, high class people, educated people living close to urban areas or more in urban areas than in rural areas, and with development of the region. So, as a community or a region develops, juvenile sex ratio goes down, and this is something to worry about. Normally people think that it is due to backwardness. No, it is not due to backwardness, it is due to modernization and due to rising aspirations and a feeling that a girl child will be a burden. Dowry can be one factor, but there are many other factors also. Thank you. So, in these two lectures we have tried to create a link between social factors on the one hand and population factors on the other. I think it will be good if you go through the original writings of Kingsley Davis and Judith Blake to understand the framework of intermediate variables, then you can apply it in any context, any circumstance. Thank you.